Thank you very much, Kostas, and thanks to the organizer for the kind invitation. I will start with this paper, this table. I always quote this in my talks because I think this is one of the most important paper published on this subject. And the reason for this is that Gonzalo is in the audience, so and he's one of my best friends, of course. So I think the importance of this paper was that they were able to demonstrate that the use of digital device in managing chest tube considerably reduced inter-observer variability. And I think this explains most of the clinical benefit of the use of electronic drainage system in managing chest tubes. And there have been several randomized trials showing the positive impact in terms of chest tube duration and hospital stay and cost saving in using digital devices. We also know that there is some, let's say, learning curve effect or confidence curve effect in using this new technology when, shifting or changing from a traditional device to an electronic device. Although there is a so-called learning curve, the positive effect or the benefits of using a digital device are evident since the very first cases. So the chest tube duration appears to be shorter, even for the first cases, compared to case-matched population using traditional devices. This is one of the last large multi-center studies comparing traditional versus electronic devices, which has been published last year in the Annals. And it was a multi-center trial, a collaborative trial, including patients from Asia, Europe, and North America. In total, almost 400 patients, most of them lobectomy, 81% performed by VATS. So it's a very modern and contemporary series to analyze the effect of the digital devices. So it was a randomization, and the two groups were managed according to a standard protocol. And you see the chest tube removal policy, which was, in terms of fluid, less than 400 milliliters per day. And, of course, the airflow criteria were different in the two groups because one used a digital device, the other traditional. The first important finding was that the chest tube duration was shorter of almost 1 day in the digital device group. And this confirms previous single institution analysis. And we know that chest tube duration is not just money. It's not just sending a patient home sooner. It is also important for pain and pulmonary function. So there have been studies showing that after removal of a chest tube, the FEV1 measure with the portable device improved considerably compared to 1 hour before removing a chest tube. And of course, static and dynamic pain is less. So it's a matter of quality of life, and it's a matter of safety and perhaps reduction of complication. So it is important to remove soon a chest tube, not just for financial reason. The other finding was the reduction in chest tube duration translated in a reduction in postoperative stay in the digital device group of about the same amount, 1 day. And this is, for me, the most intriguing finding. So the patients managed with an electronic device had a shorter airlick duration. This may be explained by two factors. First of all, of course, the definition of airlick is different between the two groups. So one is subjective, one is objective. So it's difficult to make a definitive conclusion from this graph. My other preferred explanation can be that the patients managed with digital device benefited from the regulated suction, which is provided by these electronic devices. And a regulated suction is able to influence and stabilize the intrapleural pressure. And we know from previous investigation that the pleural pressure, or the swings, the oscillation in pleural pressure during inspiration, expiration, are correlated with the duration of airlick. So patients with the big swing observed in the pleural space and the large airlick immediately after surgery have a higher risk to develop a prolonged airlick. So perhaps if we will be able to influence or modify the pleural pressure, stabilize the pleural pressure to narrow down these swings in a controlled, regulated way, maybe we'll be able to influence the sealing of the lung, the duration of airlick. And this is what happens, when you apply a regulated suction. First of all, regulated suction is a form of active drainage. And with active drainage, I mean, a drainage which is exerted by applying an external source of suction, which is performed by a device providing a variable suction level reacting to the feedback coming from the pleural space. And this is to maintain the preset suction level. So what you set in the device is what you get inside the pleural chest, inside the pleural space. And this is exactly what happens when you apply an unregulated suction. So when you plug your traditional device to the wall suction, so that is a completely unregulated. Even though the patient is on suction, you see the oscillation in the pleural pressure curves, and you see the regulated suction is the pleural pressure is very stable. So the blue line is the actual pressure measure at the chest. It's not inside the chest, but it's at the chest because the pressure sensor is close to the chest. But it's I think a reliable approximation of the average pleural pressure inside the chest, and it's very stable with very narrow oscillation. And this is another graph after a left upper lobectomy by applying this device. The red, this is a pointer. The red curve represents the airlick. So this patient had an initial airlick which stopped around here, and while the patient had an airlick, the pressure here was set at minus 12 centimeter of water, and it was quite stable, kept very stable with minimal oscillation. And then as soon as the airlick stopped, the machine stopped working as a pump and just work as a monitoring device. And this is the actual pleural pressure generated by the patient. So, and this is another advantage of these devices that act as a sort of intelligent devices. They work when it is needed to maintain the set pressure. When the airlick stops, and the pressure, of course, is maintained by the patient, they just monitor what happens in the pleural space. So I think this is important in light of what happens after a lung resection. It is important to perhaps create an environment inside the pleural space which is capable to minimize the damages of overstretching the lung after we remove the large piece of parenchyma, like a lobe. We know from the lab that the lung compliance is directly affected by the amount of tissue we remove. So if we remove a lobe or two lobes, the compliance of the remaining lobe, the remaining tissue is markedly reduced. And this means that to reinflate, to expand the lung to the same volume, we need to exert a very high distending pressure, and this creates overstretching of the residual lung, and this is the cause of many complications, as you can see here, from these pictures that I borrowed by Professor Mizorocchi. You see that by changing the transpulmonary pressure, the negative pressure, and we are talking about rabbits here, there is an increased incidence of pulmonary edema or interstitial edema because of overstretching and damage of the pulmonary, vessels and matrix. So negative pressure and intrapleural pressure may have a profound effect on the healing of the lung after resection, and I think it is important to work with industry and company to try to produce this kind of device that are able to stabilize the pressure and allow a soft re-expansion of the lung, perhaps, and minimizing the risk of over-distension, which is at the base of most of the pulmonary complication after surgery. We also investigated patient satisfaction with this device, and although you see the difference in numerical difference are minimal, there are some dimension that favor the digital device compared to traditional, like the ability to get out of bed, the patient and the personnel find more convenient the use of a digital device compared to traditional, and more patients thought that they could go home with this device if needed compared to traditional device. The other aspect of chest tube management or pleural management is the pleural effusion, the production of fluid after resection. And we know from physiology that fluid filtration mostly occurs in less dependent regions, and pleural fluid is mostly drained from lymphatics, which are mostly represented or more represented on the mediastinal aspect and the lower part of the parietal pleura. And we also know that the lymphatics act as a very efficient negative feedback system, and they are able to markedly increase their filtration or draining capability if needed. The daily physiological pleural fluid filtration is about 350 milliliter. So this is the physiological daily draining capability of the pleural space, which can markedly increase in certain situations. And of course, the residual pleural space after resection is affected by the absorption pressure of the lymphatics, and this will determine, together with, along with other physiological adaptation, or adaptive mechanism of the lung, the residual pleural space. We know from this and other more recent studies that it is safe to remove a tube even with a high output. Now, how to define a high output is sometimes less clear-cut in the literature. I know the Copenhagen group has recently published, and I will show you later, a similar paper. Although all these papers show that it is safe to remove a chest tube with a drainage less than 450 or 500 a day, it is not clear from this paper how many patients actually had this amount of volume at the time of chest tube removal. We know that in general the incidence of readmission of need of another or tube reinsertion is very low if we adopt this high output criteria for chest tube removal. So we try to investigate this aspect, and we used a similar cutoff. This is the threshold we use in Leeds, so 400, 450, and this has been used since many years without much of a complication. But we wanted to see and to develop a risk score to predict the patients at risk of developing a large pleural effusion defined as a greater than 400 on postoperative day 2. And the reason for this is if we are able to predict immediately after surgery which are the patients that are at risk of large pleural effusion, then we can try to prolong for another day, perhaps, in the chest tube duration to avoid, complication at a later stage. And we found that, first of all, the incidence of large pleural effusion, so a drainage more than 400 on the second postoperative day, is not negligible. It's 23%. So 1/4 of the patients had a large pleural effusion on postoperative day 2 with the drain in situ. And these are the variables that turned out associated with a large effusion after surgery. So elderly age, lower lobectomy, and COPD. We can discuss, why these factors are associated with a large pleural effusion, but anyway, they contributed to make a score, and you see the distribution of the patients according to the score. But most importantly, you see how the score stratifies well the incidence of a large pleural effusion on postoperative day 2. We chose postoperative day 2 because we usually do not remove tubes on postoperative day 1, and this is another after lobectomy. And this is another point we can discuss, but also it comes from another finding that, a large proportion of patients, about 10-15%, can develop what I call intermittent or recurrent air leak. So an air leak that is not evident immediately after surgery or stop after surgery and then, recur within the first day or on the second postoperative day. So we found safer to wait at least 1 day, even in the absence of air leak, to remove a chest tube after lobectomy. So 39% of patients with a high score with 2 or 3 factors can develop or have a risk of developing large pleural effusion on postoperative day 2. By using an electronic device, we can now track down the rate of diffusion after surgery, after lobectomy. And you see this is the diffusion is averaged every 6 hours. So during the first 48 hours, the first 2 days after surgery, the effusion rate, the drainage rate, on average, reduced or dropped from 20 milliliter per hour to 10 milliliter per hour. This is the average trend that can be followed, after lobectomy. All these evidences can help in anticipate the chest tube removal if deemed safe in certain patients. This is the paper I discussed before. Although the threshold of 500 milliliter per day appears safe after lobectomy, after VATS lobectomy, still 3% of patients required tube reinsertion. Perhaps using risk scores or stratifying criteria, we can minimize this risk by predicting those patients that at a highest risk to have a large effusion after surgery. This is another study that will be presented on Friday from our group. And we perform a propensity score case-matched analysis between VATS lobes and thoracotomy patients to see whether there is a difference in approach. This is not a randomized trial. At least in our institution, it's very difficult to randomize now VATS versus open cases because 75% of lobectomies are done by VATS, so we don't think randomizing patients to thoracotomy at this stage, where all consultants are doing VATS, is quite right for the patients or ethical. But still we try to gain some evidence by using a case match analysis, and we didn't find, surprisingly, any difference in terms of average amount of drain between thoracotomy and VATS. This is a daily drainage on postoperative day 1 and day 2. And also the proportion of patients with a large pleural effusion on postoperative day 1 and 2 was quite similar. Paradoxically, there is, or unexpectedly, there is no evidence that VATS reduce pleural effusion in our institution. This may be, due to the type of thoracotomy we do, which is still a muscle-sparing limited thoracotomy. So probably, there is not much difference in terms of pleural effusion. The lymphadenectomy is the same inside, so this may be another factor that can contribute to a similar pleural effusion after lobectomy. So it is not the approach that influence the effusion. We now have devices that are able to continuously monitor in real time, not just the air leak or the measure pressure inside the chest, but also the fluid. And perhaps these devices can help in setting or selecting some criteria for a total digital chest tube management. We found, for instance, that so in this case the blue line is the air leak. The gray straight line is the set suction level, which is -2 kilopascal, and the gray line, this toothed line, is the measure pressure. And you see that again that the measure pressure start to show oscillation, which is the actual pressure built up by the patient before the airlick stop, immediately before the airlick stop. This is a sign that the airlick has stopped. So it's an earlier sign than the airflow itself. And also, we can perhaps find a deflection point in the fluid drainage or fluid effusion that can help us to anticipate chest tube removal. This is not used yet in this type of graph in the clinical practice. We have the devices, that can give us the averages on the bedside. We are not able to use this kind of graphs or integrate this information to find algorithms to perhaps establish when it is safe to remove early a chest tube. But I think this will be probably the future in chest tube management. So in conclusion, digital devices are safe and user-friendly with a short learning or confidence curve. For sure, they are very effective in reducing inter-observer variability in deciding when to remove a chest tube. They have shown to reduce chest tube duration and hospital stay in many single-center or multi-center investigation. They are able to improve patient satisfaction and staff probably satisfaction with the drainage system, and they are able to deliver a regulated type of pressure suction that can help in promoting sealing of the airlick and prevent overdistension of the remaining parenchyma. Thank you very much for the attention and kind invitation.